In this lecture, we are going to talk about acquired cardiovascular disorders. Acquired is something that the child is exposed to that caused it. For example, the child had strep throat and developed rheumatic fever. In utero, the baby's circulatory system functions differently than it does after the baby is born. The placenta is the organ of gas exchange rather than the lungs. This is accomplished by fetal circulation having certain adaptations to make a continuous loop. This includes the umbilical vein and arteries, the ductus arteriosus, and the foramen ovale. The neonate's first breath triggers the start of several cardiopulmonary changes to help the neonate transition from fetal circulation to postnatal circulation. During this transition, the foramen ovale and ductus arteriosus close, and the umbilical vein and arteries are clamped. These closures allow blood to start flowing to the lungs. The primary function of the cardiac system is oxygenation and perfusion. The anatomic structures of the heart help to fulfill these functions. The heart is divided into 4 chambers, 2 atria and 2 ventricles. A septum, or wall, separates the left and the right side of the heart. The heart has valves that open and close to control the flow of blood between the atria and the ventricles. The great arteries, the aorta and the pulmonary artery, carry blood away from the heart to either the body or the lungs. Pulmonary veins and the superior and inferior vena cava return the blood to the heart. Let's take a minute to discuss normal blood flow through the heart. The heart can be divided into the right and left side. The goal of the right side of the heart is to deliver unoxygenated blood to the lungs to become oxygenated. The goal of the left side of the heart is to take the oxygenated blood and to deliver it to the organs and tissues. After the body has used up the oxygenated blood, it is going to drain the unoxygenated blood through the superior and inferior vena cava. Next, it will go down through the right atrium. As the blood fills the right atrium, it initiates a contraction, causing the tricuspid valve to open. The blood then enters into the right ventricle. The heart has a tricuspid valve on the right and a bicuspid or mitral valve on the left. A good way to remember this is the saying, try before you buy. Try for tricuspid and buy for bicuspid. Back to our blood flow though. The right ventricle is going to contract. It is going to squeeze and pump the blood up through the pulmonomic valve and into the pulmonary artery. The blood then travels to the lungs. In the lungs, the gas exchange occurs in the alveoli sacs. Oxygen that has breathed in is going to cross over into this blood, and carbon dioxide is going to cross over to be exhaled. The blood is now oxygenated and is going to go to the left side of the heart through the pulmonary vein. It will then go down through the left atrium. As the left atrium fills, a contraction is initiated, causing the bicuspid valve to open. The blood goes through the bicuspid valve into the left ventricle. The left ventricle is really strong and squeezes the blood up through the aortic valve to the aorta. The blood is then shot throughout the body to replenish the organs and tissues. This chart also goes over blood flow of a normal heart. Your book has this chart on page 1190. There are some pediatric differences in the circulatory system. The first difference is the transition from fetal circulation to pulmonary circulation after being born. It is important for nurses to assess newborns frequently during the first 24 hours of life to make sure that cardiac compensation has occurred, since circulation and perfusion are essential to life. Another difference is vital signs. Typically, pediatric patients have higher heart rates and lower blood pressure. Before the age of 3, blood pressure is not a good indicator of perfusion, but as they become older, it is an important indicator. The heart rate is usually fast. It starts out around 110 beats per minute and decreases to 85 beats per minute by 16 years of age. This is due to the fact that the left ventricle is not fully developed until the age of 5. The higher heart rate is needed to obtain the appropriate cardiac output needed for the heart to function. It is not uncommon for the heart rate to vary with inspiration, and a sinus arrhythmia could be a normal finding as the child ages. For example, a child may have a murmur. If they are asymptomatic, it can be monitored, and the child may outgrow the murmur. Children have some anatomical differences that can make the cardiac assessment a little different. For children under the age of 7, we use the fourth intercostal space, not the fifth, to assess the apical pulse. Part of this is due to the smaller heart size. Another pediatric difference is the ejection fraction, the fraction of outbound blood from the heart. This is used as a general measure of cardiac function. In newborns, the right ventricle is larger, and it takes a little time for the left ventricle to develop, which can result in a decreased ejection fraction. Infants have a greater risk of heart failure than older children because the immature heart is more sensitive to volume or pressure overload. In emergent situations, cardiac compensation can occur for extended periods of time in children, much longer than adults. However, children then quickly decompensate. This slide shows some components of the cardiovascular assessment. Your book also outlines the assessment on page 833. The object of the cardiovascular assessment is to identify any issues and determine if the body is compensating for those issues. If there is an issue, we want to look for any reversible or treatable causes. The most common treatable causes are often referred to as the H's and T's. If a baby or a child is having perfusion or oxygenation problems, we look through the H's and T's to find the cause. The H's are hypovolemia, and for that one, our treatment would depend on what the child lost. Either blood or fluids are going to be given. Hypoxia, we would give oxygen. Hydrogen ion or acidosis, that could be reversed using sodium bicarbonate. Hypoglycemia, hyper or hypokalemia or calcemia. Hypothermia. For that, for a newborn, we would dry them, put them skin to skin, swaddle them. We could put a hat on them, stick them under a warmer, try to warm that kiddo up. For T's, toxin, tension pneumothorax, trauma, and thrombosis. This slide shows some possible client problems when perfusion is impaired. Why do you think fear could be a problem? Well, parents could fear what happens if it doesn't work out with heart issues, or even the child if they're older. Altered gas exchange can be a problem. The heart can't get the blood to the lungs for the gas exchange. We're going to see cyanosis and decreased O2 sats. Activity intolerance also can be a problem. These kiddos are not able to do normal activities for their age. These babies can't eat without getting tired and are often sweaty. They need extra rest breaks, lots of naps, and just a little extra time. When you think about problems, think about what it would be evidenced by, and then what interventions you would want to do for them. Nursing interventions when caring for a child who has an altered cardiac function could include fluid boluses for hypovolemia. A lot of times they'll use those isotonic crystalloids, the normal saline or lactated ringers. A bolus can be given over 5 to 20 minutes, and they used a weight-based formula. Toxins could be treated with a reversal agent, and they may need nutritional supplementation due to getting tired too easily with feeding. Medications can be used. Surgical interventions. It's really important to support the family during this time. It can be a really scary time for parents, and then sometimes we need to provide palliative care. The first acquired heart disease that we are going to talk about is rheumatic fever. This is an inflammatory disorder of connective tissue that results from an autoimmune response to some strains of strep throat. This disorder may cause long-term damage to heart valves and affects joints, brain, and skin tissues. It occurs most commonly in children between 5 to 15 years of age, and it is estimated that 60% of the patients with acute rheumatic fever will develop rheumatic heart disease. However, while this is a serious health problem, the incidence is very low in the United States due to screening for strep and earlier treatment for it. That is why it's also important to educate on the importance of finishing the entire antibiotic. Symptoms of rheumatic fever usually begin 1 to 3 weeks following the strep infection. The signs and symptoms of rheumatic fever are divided into major and minor symptoms according to the Jones criteria. Joint inflammation may occur in large joints. This inflammation can be migratory and move from joint to joint. Subcutaneous nodules can also be noted over bony prominences and along tendons. The nervous system can be affected in severe cases. Sydenham chorea is a syndrome of aimless movements of the extremities and facial grimacing. This slide just shows a mnemonic to help remember the major criteria. Erythema marginatum is a rash that is seen with rheumatic fever. It is considered to be a major symptom. The rash is unique because it strictly stays on the trunk and will not spread to the hands or the face. It does not itch, but it will blanch in the middle of the pink areas. Carditis may develop 1 to 3 weeks after an untreated strep infection. It usually involves the mitral or aortic valve and may be detected by the development of a new murmur. Heart failure can occur from either a severely narrowed or leaking heart valve. Children in a state of heart failure, regardless of the underlying etiology, will initially present with similar clinical symptoms such as tachycardia and tachypnea. Infants and young children may present with poor feeding and failure to thrive, whereas older children may complain of fatigue, exercise intolerance, and breathlessness. Congestive heart failure is more difficult to detect in infants because it may be more subtle. The infant may be noted to have rapid respirations and to use accessory muscles with breathing. The infant will tire easily, may be diaphoretic, or may have difficulty sucking because of the dyspnea and the energy required to eat. A child may gain weight from the fluid overload, but more frequently an infant will lose weight because their caloric expenditure is greater than the caloric intake. Right-sided heart failure leads to hepatomegaly, increased venous pressure noted in jugular venous distension in older children, or periorbital edema. Left-sided failure results in increased pulmonary pressures, rales or crackles, tachypnea, and shortness in breath. Diagnosis is based on the Jones criteria. To have a diagnosis of rheumatic fever, children must have 2 major criteria, or 1 major and 2 minor criteria, plus laboratory evidence of a strep infection, either a positive culture for strep or an elevated ASLO. An echocardiogram may be used to monitor for carditis and look for damage to valves and other structures. Treatment involves antibiotics to treat the strep. The child should also be on bed rest for several weeks if carditis is present. We do not want them to overwork the heart. If carditis is not present and arthritis is the major manifestation, then bed rest is only 1 week. Aspirin is given to relieve joint pain. It is also important to handle and position the child's joints carefully. Safety is also a factor if the child has chorea. Reassure the parents and child that the effects of chorea will eventually subside. After discharge, long-term antibiotic prophylaxis is initiated. The child will be on this medication until adulthood to prevent reoccurrence of rheumatic fever. It is important for the parents and child to understand that if the child has a sore throat, they need to have a rapid strep screen and a throat culture. It could still be strep even with them on antibiotics. The child may need a different antibiotic for the infection. Heart function must be monitored for life to watch for changes and provide early intervention. Kawasaki disease is an acute febrile systemic vascular inflammatory disorder that affects the small to mid-sized arteries, including the coronary arteries. Arterial damage can occur within a week of fever onset and can lead to the formation of coronary aneurysms, which will predispose the child to thrombosis formation and a high risk of myocardial infarction. Kawasaki disease is sometimes called mucocutaneous lymph node syndrome because it also affects the lymph nodes, skin, and the mucous membranes inside the mouth, nose, and throat. The cause is unknown, but it is thought to be related to an infectious agent. This agent exposure results in an exaggerated immune response. It is the leading cause of heart disease in children and leads to 5,000 hospitalizations a year. Children under the age of 5 account for the majority of cases. The good news is that you usually only can get it one time in your life. There are 3 stages of the disease: acute, subacute, and convalescent. The acute phase lasts 1 to 2 weeks and is characterized by irritability, a high fever that persists more than 5 days, conjunctivitis, red throat, swollen hands and feet, rash on the trunk and peri area, enlarged cervical lymph nodes, diarrhea, hepatic dysfunction, and a strawberry tongue. The strawberry tongue is pretty common with this disease. The tongue is red and swollen, and the taste buds stretch out to look like seeds. The subacute stage usually lasts 2 to 4 weeks. It is characterized by no fever, cracking lips and fissures, peeling of the skin on the tips of the fingers and toes, joint pain, cardiac disease, and thrombocytosis, too many platelets. The convalescent stage is usually 6 to 8 weeks after the disease onset. The child appears normal but has lingering signs of inflammation. Diagnosis is made with a high fever for 5 days or longer, along with 5 of the principal features. Your book has a table 4710 on page 1222 that goes over the diagnosis. Kawasaki disease is treated with a single high-dose IV infusion of immune globulin, IVIG, over 10 to 12 hours. It must be given within 10 days of the onset of the disease in order to reduce the risk for coronary artery aneurysms. Live vaccines must be postponed for 11 months after receiving immune globulin. High doses of aspirin is given for the high fever and to promote comfort. A low dose of aspirin is given daily once the child is afebrile for 2 to 3 days to reduce clot formation. Kawasaki treatment is a rare exception to the rule that aspirin shouldn't be given to children and should only be given under the supervision of a doctor. Aspirin has been linked to Ray's syndrome in children recovering from chickenpox or the flu. These children are hospitalized. The duration of the hospitalization depends upon the presence of cardiac lesions and how long the fever persists. Nursing care focuses on promoting comfort, monitoring for early signs of complication or disease progression, and supporting the family. After discharge, the child will need follow-up care to monitor for cardiac complications, hypertension, and hyperlipidemia. These patients could have the complication of an aneurysm and could have congestive heart failure due to the arterial disease.